Just going to bring up the PowerPoint.
Yeah, that sounds good to me.
Slideshow. And are you able to just see my slides, no presenter view or anything silly like that?
Yes, yeah. This seems to be the recent default with the latest issue of the latest version of Zoom. So the recording ends up showing mainly the slides. Yeah, so it's 2 o'clock. I think you can start.
Perfect. Sorry, one sec. So hello, everyone. I'm really happy to see you. It's so nice doing a Zoom presentation where people have their cameras on, because sometimes it feels like you're just talking to yourself to a blank screen, and that was no pressure for everyone to turn their cameras on. Please don't take it that way. It's just nice to see some people's faces, so I really appreciate it. So today I wanted to talk about futurism and ethics. But to be honest, it's really hard to anticipate the future. And although I like to think of myself as a future thinker, I felt that for today's presentation, we should probably talk a little bit more about the past and also about the present. And then depending on how the conversation and discussion goes today, we can take the next seminar in a very different direction if you like. I am more than happy to distribute these slides if you like. I just always put this slide as a reminder for myself that there's some nice health ethics seminars coming up in the coming week. There's another one circling around systemic racism this week on Thursday, so please feel free to join us if you have the time. They're always open to all members of the public. So my objectives for today were to describe moral philosophy as a socio-cultural phenomena, particularly as it's often reduced to ethics, or ethics is often reduced to moral philosophy. 2, to describe principlism as an example of moral philosophizing. To provide an example of applying principlism to a clinical case. And lastly, to discuss how imagined socio-cultural shifts may reshape ethics in the future. And I'm really leaving that last point more open for discussion. Okay. All right, one second. I'm just going to close my door. So what do I mean when I say that moral philosophy is a socio-cultural phenomena? Usually when we talk about ethics, we think about ethics as a branch of philosophy, recognizing that philosophy is a discipline of questioning. But philosophy itself is a cultural phenomena, a theoria that really started with the ancient or the early Greeks. When you look at the origin of the word philosophy, etymologically, ethics originates from ethos, meaning the moral atmosphere of a people or a community. And then the online etymology dictionary gives the etymological meaning of ethos as the genius of characteristic spirit of a time and place, indicating that ethics and ethos are phenomena deeply embedded in the ancient history of humanity. Now, why is that important for any discussion of ethics in our contemporary world is because we need to acknowledge that ethics doesn't come out of nowhere, right? It's bound by certain cultural understandings. And what may have been considered right or wrong yesterday might appear different today. And then we also have to begin to wonder what will be considered morally right or wrong in the future, particularly if there are shifts in how we live together or shifts in how we think. When people talk about ethics or moral philosophy, they often tend to, their thinking tends to center around one of these perspectives. And I think it's really important to articulate what these perspectives are, because then you can often begin to identify a person's particular style of thinking, all right? So we're going to talk a little bit about deontology, consequentialism, character perspectives, communitarian perspectives, contractualist perspectives, and cassiatry. Now, I'll remind you guys that I'm actually a physician in newborn intensive care. So I'm a really pragmatic guy. So I'm not a philosopher. So I'm going to try and make this what I hope is very understandable. But please stop me at any point and we can discuss any of these concepts in more detail. So what's important to think about with any of these perspectives is to ask the question of where is the good located as far as how we recognize what is good, because it differs in these different perspectives. All right. A deontological perspective is sometimes referred to as obligation ethics, duty ethics, or rule-based ethics. And here, morality, meaning what is decided as what is right or what is wrong, is determined based on how it conforms to those central obligations. In other words, it comes from the Greek word dion, which expresses obligation, that which is binding, okay? Now, most of us recognize forms of deontological ethics. If we think about the Decalogue, the Ten Commandments, the sayings, because these lists or these scriptures consist of prohibitions and prescriptions, such as thou shalt not kill or honor thy father and thy mother, right? So one is doing good if one is honoring thy father and mother, if one conforms to that obligation. Does that make sense? Yay, I see some noddings of faces. This really helps me. I'm a visual guy. So deontological ethics is often tied up with Immanuel Kant, right? And Immanuel Kant's first formulation of the categorical imperative, and if you attend any ethics talk, it's useful to have heard of the categorical imperative, expresses what would be considered the foundational principle for his philosophy, which is act only according to the maximum, whereby you can at the same time will that it should become a universal law. What does that mean? In the very basic sense, do unto others as you want done unto yourself, right? So what is morally good would be defined as those actions that you would expect should become universal law. So if there's something good about not killing, you would hope that everyone follows that same prescription or obligation of not killing. Does that make sense? So that's the foundational principle. Now we're going to talk more about principalism, but principalism is often articulated as a modern deontological ethics, because the foundational principles, which come from something called the common morality, which we'll come to in a sec, are to do good or beneficence, to avoid harm, non-maleficence, to respect the independence of the patient, autonomy, and to be equitable, right? Which relates to justice, right? We also find deontological systems of ethics expressed in many professional codes of ethics. So if you were to look at the Alberta Medical Association or the Canadian Medical Association or nursing ethics codes, you'll find often listings of prescriptions of things that a physician or a nurse or other healthcare provider should engage in, right? So whenever I'm hearing someone giving a deontological argument for ethical action, I'm always listening to what rules are they describing, right? And this is how deontology is useful as a heuristic. Heuristic meaning a way of questioning a particular situation of what action should be undertaken. So already thinking a little bit about the future, one question could be asked is, what principles do we anticipate, or what obligations, what rules do we appreciate are going to be present in society in the future compared to right now? What guiding principles are going to be important in guiding our action, right? Even just looking at the COVID-19 pandemic, we can see that different principles have come to the forefront, right? and other principles that previously were highlighted are kind of moved into the shadow, right? So a principle that's often highlighted in COVID-19 response and resource allocation is the principle of utility, right? The principle of maximizing good, right? Or ensuring that resources are applied in such a way that a possible outcome is maximized. And then principles like autonomy or rights relating to, say, disability ethics may be put into the shadow. So already now, think about what principles do you foresee appearing in the future? So what's often put in opposition to deontology is consequentialism, all right? So if we say that principlism, or I should say deontology, locates ethics or the moral or what is good in what binds it, right? Consequentialism locates what is good in the outcome of an action, right? So sometimes the term teleological ethics from the Greek telos is also used in the place of consequentialism, meaning the end, the limit, the goal, the fulfillment, the completion, all right? So people often recognize consequentialist ethics when they hear expressions like the end justifies the means. It's not the principle that confers whether an action is good or not. It's the outcome that was achieved. Does that make sense? Now, there are different kinds of utilitarianisms or consequentialist ethical theories that stress different outcomes, whether we're talking about happiness as an outcome, well-being as an outcome. And we also hear about deontological consequentialist theories, such as principlism, where one of the principles is actually an expression of consequentialism, like beneficence, non-maleficence. Okay. So when we look at a situation from a consequentialist perspective, we ask what ends ought to be achieved. And there's certainly lots of post-apocalyptic futuristic movies or other things appearing in the media where essentially ethics seems to collapse into striving for a particular end, right? What about character-based ethics, right? So here, what is good or what is moral is not located squarely as far as what binds it or the outcome that it's achieved. It's rather in the character of those who are carrying out the act, right? And the notion of virtue is traced actually back to, again, the Greek word for excellence, aret, right? And in its basic sense, aret means excellence of any kind, literally that which is good. So this notion of excellence was bound up with the notion of fulfillment of purpose or fulfillment of function, right? So what makes a good physician? What makes a good nurse? If I want to look for the right course of conduct, I should ask myself, what would a good nurse do in this situation? What would a good doctor do in this situation? How are good nurses and good doctors different? What characteristics make them different? Does that make sense? So you see, that's a very different focus for ethics than either deontology or consequentialism. Then there are communitarian perspectives. Communitarian derives from the French communier. I'm sorry, my French accent is horrible today. I've been drinking too much coffee. I'm blaming it on that. Meaning to make common or to share, or common, general, free, open to public. Communitarian perspectives displace ethics or this sense of what is good away from the individual actor to what's shared in common, all right? A good example of a communitarian ethics is narrative ethics, right? Where ethics is located not just in the actors, not just in what happens, not just in what principles might be guiding people's actions or other obligations, but how everything comes together, right? If I can talk about an event that happened in the NICU, so my workplace, in a free and easy manner, there's something good about it that holds together in a story where that story can be shared, that speaks to the goodness of the situation. But the goodness cannot be traced simply to any individual's actions nor any particular outcome. It's rather how everything comes together in common. Other examples of communitarian ethics are relational ethics and ethics of care, which comes from feminism, right? Some people really love communitarian ethics, but other people accuse it of being very vague, right? Because people are wanting something to nail down what to do every time. And clearly these cases can sometimes live with us in different ways. What about contractualism? All right. So contractualism posits that we create morality by our agreements with one another. So from this perspective, nothing is moral or amoral in advance. It's rather formed or comes into being based on what we agree to with each other, right? It's realized in our contracts with each other, right? So contractualist perspectives are associated with people like Thomas Hobbes, and informed consent in healthcare is, you could say, an expression of contractualist ethics, all right? So a surgeon can perform an operation because they receive the consent of their patient or surrogate decision maker. They are performing a good act to the extent that their actions are in keeping with that contract that was formed. Does that make sense? And contractualists often look at all the various agreements we form with one another, often to look at even socio-political ethics, right? So what's going on right now between allied health providers and the government, what kind of contract, what kind of agreement was formed there? And when one party breaks that contract, what obligations do you still have towards one another, right? But you can see how this also creates a problem for ethics, because it doesn't mean there's any absolute right or wrong. It's rather we redefine what's right and wrong with each agreement we create with one another. And then we have casiatry perspectives or pragmatic perspectives. This is an approach whereby morality, meaning what is good, is not viewed as something out there, but rather residing in the particularities of a case. And on one hand, you might say, well, isn't that the same as like a narrative ethics? And no, it's somewhat different, because for a casiatry perspective, it's not just this particular case, this particular event, but it's this case and what has happened in this case comparing to previous cases, right? So casiatry is often linked with notions of jurisprudence, right? Jurisprudence and ethics in the law, right? Where we define what is right based on our previous rulings and our previous judgments of similar or different cases. If we previously said it was right to do surgery on babies who have severe neurodevelopmental deficits or brain injuries, then surely it is still right going forward because we previously did it and said it was right at that time, right? Now, of course, where this runs into issues is we're dealing with this question of, well, just because we describe something as is doesn't mean that is the way something ought to be. And we can learn from cases and recognize we make mistakes. Any questions about those different perspectives? No? Okay. So that's a really quick summary of different moral perspectives. But I wanted to focus on principlism because I realized the last seminar I attended, we talked about this in very brief terms. And really in contemporary healthcare and medicine, this is the dominant approach to health ethics. To the extent it's taught at the expense of these other approaches. So I'm always a little reluctant to go into it in too much detail. But on the other hand, I think for any kind of discussion of health ethics, it's important that we acknowledge it and discuss kind of its limitations and its strengths. Okay. So principlism, like I said, is drawn from deontology and consequentialism, and it includes these 4 principles. Got it? Great, we're done. See you later. No, I'm joking. All right. So where did principlism come from? All right. So principlism, as far as kind of the name and those 4 principles, really emerged in the 1970s in response to various publicized scandals in both biomedical research as well as occurring in clinical practice, which isn't unusual. We have a history of this in health, right? We learn from some mistakes and we come up with some kind of documents to guide future actions to prevent them from ever happening again. That's also true for things like the Declaration of Helsinki, right? That came about after the Nazi experiments in World War II, right? And there were 3 studies I'll just point to as examples, just to show you what was happening in the wake of the 60s and 70s that led to the development of principlism. Because I imagine some of you who are attending here today may have actually been born shortly after the 70s or in the 70s or before, right? So this wasn't that long ago. So the first was the Fernald School radiation studies. And essentially during the 1940s and 1950s, there were these boys at this Fernald School for the mentally retarded. All right, I'm sorry if my language is not right, but I'm saying it the way historically they were described. And this was in Massachusetts. And essentially these boys were used as participants in experiments that involved the ingestion of radioactive materials, right? So milk and other breakfast foods were laced with radioactive tracers and fed to these boys who were around age 12 or 17 so that they could study how is iron and calcium absorbed and handled in the body. Now, clearly nowadays we wouldn't be doing such experiments on otherwise healthy children, right? But where the public outrage came in response to this study wasn't simply that these were children and who were otherwise healthy, but the parents of these children were not clearly informed that their children were actually participating in any of these research studies, meaning consent to participate was actually given by the staff who worked in the facility, right? So there was no clear consent that was provided, okay? Eduardo, I saw your eyebrows move upwards. That was great. Then there was the Willowbrook hepatitis study. So from 1956 to 1972, again, physicians experimenting on children where they essentially infected 800 cognitively impaired children who lived at this Willowbrook State School in New York. And the idea was to deliberately infect these children with a hepatitis virus. At that time, we didn't know what hepatitis A was compared to B, compared to C, right? And to study the course of illness from the time of infection, right, till presentation of symptoms and so forth. Now, what was so challenging about this study, and again, why it received public outcry, is that this school was very hard to get your children into, right? And many of these children clearly required a great deal of care. So parents were, it was made easier to get your child into the school if you agreed to have your child participate in one of these research studies. Right? And then as time went on, as the school became quite full, child participation in a research study became a requirement to have your child attend the school. So although there was a consent process that was followed of the parents, one could hardly say that consent was free, that it was without coercion. Does that make sense? And then, of course, the Tuskegee syphilis study from the 1930s to the 1973. Another American study, and I'm using these American examples because they're popularized in the literature, but please believe me when I say we have our own Canadian history, which is certainly not shiny, in which syphilis was studied. And what was done is investigators sought out Black men. These men were by and large working on crops, and they were enticed to participate in a study which would offer them free medical examinations and special treatments for an ailment described as bad blood. Now, what actually happened were these people, once they agreed to participate in the study, they were deliberately infected with syphilis. And the free medical examinations that they were receiving and special free treatments were actually diagnostic procedures used to study the natural progression of syphilis, like lumbar punctures. Okay. The false belief that treatment was being administered prevented participants from otherwise seeking medical treatment for their disease. And when participants did attempt to acquire medical attention from another source, community physicians not associated with the study were instructed not to treat the syphilis. And this was in the context of a available treatment, penicillin, known to be effective for syphilis, right? So this study not only resulted in a number of men dying as a consequence of syphilis or otherwise suffering complications from syphilis, but also these same individuals infecting their family members with syphilis. So in response to studies like these, and these are just a sampling to give you a sense, there's actually a really famous New England Journal article, although it's from the 1940s, which described many such experiments, came two very highly influential publications. The first was the Belmont Report from the National Commission for the Protection of Human Subjects, that was in the United States. And this specified 3 principles for research oversight, including respect for persons, beneficence, and I'm pretty sure the third was justice. I wrote this down on my notes because I always get these two confused with a different declaration. Yeah, respect for persons, beneficence, and justice. And then the second major publication that came out was the first edition of Principles of Biomedical Ethics by Tom Beauchamp and James Childress. And since that time, there have been numerous editions of Principles of Biomedical Ethics and teaching of these principles to people in medical training and related disciplines. All right. So why is it important to look at the history? Because it's important to consider in any futurist consideration of ethics, what possible future world events could reshape how we think about ethics, right? So I already described this, foundations of principlism on deontology and consequentialism, and I kind of pointed that within 2 kind of common traditions within moral philosophizing. Now, what's important about principlism, which we often don't acknowledge, is that principlism in and of itself is supposed to express a global and cross-cultural morality, right? Meaning regardless of whether you're Christian, Sikh, Jewish, that these principles would apply to you, right? Which actually is a little bit problematic because it levels other principles that might be very important for other cultures. For example, I was attending a talk earlier last week on Indigenous ethics and the notion of the principle of reciprocity, right? We don't necessarily think about that in medicine on a day-to-day basis because it's not one of the 4 principles, but that's a very important principle for other cultures. Right? Now, what makes respect for autonomy an appropriate principle and beneficence and non-maleficence and justice? Why are these the principles compared to other principles? Well, there's actually people who argue that there are different principles that we should follow. But the authors of like principlism, like Beauchamp, Childress, and other followers would say that these principles reside in what's known as the common morality, meaning what we would generally accept as members of a society, right? And these principles themselves are not specific to culturally specific moralities, right? So there are certain cultures which, for one reason or another, value men more than women, right? As just an example. Now, I think in Canada, North America, I'm hoping many places in the world we're changing, right? To recognize we're equal, but clearly different cultures have different moralities, right? The common morality is the set of norms shared by all persons committed to morality, right? So committed to doing good. The common morality is not merely a morality in contrast to other moralities. The common morality is applicable to all persons in all places, and we rightly judge all human conduct by its standards. So I wanted to talk a little bit now about the individual principles just to clarify them again, because these are so important in health ethics. The first is respect for autonomy. So conceptually, being autonomous includes two conditions: liberty, right? So liberty meaning freedom, the absence of controlling influences. You are free, you're liberty. And agency. Not only are you free, but you're able to self-initiate your actions, right? So respect for autonomy, if I were to ask like my neonatal intensive NICU trainees to articulate it, they would say it says, respect for an individual's self-rule from both controlling interference by others and from limitations that prevent meaningful choice. And what principalism ends up creating for healthcare professionals is both negative and positive obligations. A negative obligation such as not subjecting your patients to constraints, right? Such as coercion, right? And positive obligations to appropriately inform, educate, encourage, or otherwise support patients in their autonomous decision-making. So it's not enough that we don't control our patients or we don't coerce them, but we are also obligated to support their informed decision-making. Does that make sense? Non-maleficence relates to not causing harm or risking harm to another in a form of their interests. But what constitutes interests is a very broad construct, right? So interests can be understood as holistic or welfare advantages or conditions. So things like health, not just meaning you have control of your blood pressure, right? Or you don't have clots forming in your legs, or you're treating your sore throat, but health in the broader sense, right? Including mental fitness, social inclusion, and other opportunities. So for healthcare professionals, this creates negative obligations, right, to abstain from causing harm or engaging in an activity that risks harming patients. And now, non-maleficence isn't all that new, right? This is, you can trace it back to the Hippocratic oaths of do no harm, right? The next one is beneficence or acting. So coming to assistance of those in need of treatment or in danger of injury to support their interests. And interest is understood in that same broad sense. And beneficence here is really the other side of non-maleficence. Recognizing while non-maleficence creates negative obligations, beneficence creates positive obligations, meaning acting in a particular way to benefit patients or prevent harms to them, right? And then justice includes a diverse array of obligations that benefit both the patient and society at large, right? And so broadly, we can talk about justice as I should get what's coming to me, right? I want fair and appropriate treatment in light of what is due or owed to me as an individual. But we can also talk narrowly about distributive justice, meaning fair and appropriate distribution of benefits and burdens within society. It's unfair that a particular segment of society, the 1%, That's all the benefits from how our society is currently structured. And it's unfair that a certain segment of society suffers from all of the burdens, right? Now, principles in and of themselves can be understood as quite abstract in order for them to be universal. Meaning when we're actually dealing with real life situations, we need to specify these principles. We need to fill out these principles and apply to a particular situation requires us to draw on our own moral perspectives, our unique moralities, right? So potentially our sociocultural, religious, and institutional sources for how to act. And here we have the word specification, which describes this filling out of an abstract principle to something more concrete. Balancing, meaning weighing one principle against another. And ranking means often putting an order of one principle before the other. All right, so I wanted to use an example just to, again, describe something that for me, when we talk about futurism medicine, is actually very contemporary. And this case was written up from this paper by Strong. Again, I'm more than happy to distribute these slides if that's something that's useful to you. So I'll just read this to you and I'll fill it out as we go along. So why is this important? And why is it more of a futuristic theme? Because babies with trisomy 18, just a few years ago at the start of my training, we would never, ever consider operating on them. We would say that they're born with a lethal genetic condition. And the best thing that we can do is to ensure their comfort. But increasingly, we are now using various medical interventions to keep them alive, right? So a female newborn was diagnosed by karyotype to have trisomy 18. Trisomy 18 means an extra copy of chromosome 18. This is very different from trisomy 21 or Down syndrome, okay? Kids with trisomy 18 have a very different prognosis. In addition to the findings of trisomy 18, the baby was found to have a heart murmur and an X-ray showing an enlarged heart, suggesting of a heart defect. And in this case, a ventricular septal defect, meaning a hole in the two pumping chambers of the heart, or a coarctation of the aorta, so a narrowing of the aorta. Now, ventricular septal defects, those don't usually require surgery till kids are about 4 to 6 months of age, but coarctation of the aorta requires surgery generally in the first week of life if a baby is to survive and get out of a hospital setting. Also, the infant had an esophageal atresia. So this is a condition where your food tube connecting your mouth to your stomach is not fully formed. So you're unable to swallow food because there's an interruption in your esophagus. And usually children who have esophageal atresia, because they can't swallow their secretions, they end up aspirating their secretions into their lungs and become quite sick, okay? Infants with trisomy 18 have a poor prognosis, recognizing to say that is also expressing a value judgment. 30% die within the first month and 50% by 2 months. And I won't kind of go into arguing, is it 50% or 80%? That very much also depends on what decision-making you make regarding interventions. Of the rare kids who survive past a year of age, they usually have severe mental impairments. So these are children by and large who aren't able to talk, right? They aren't able to ambulate usually independently, right? So long-term survival is rare. For this particular baby, several life support measures have already been provided while waiting for the karyotype to come back. The first is that an IV was started and the baby's receiving sugar water and electrolytes, right? And that's a normal thing that we do when a baby's born when they can't eat, right? There are also other life support measures were being considered. So the question was raised, should the esophageal atresia be corrected, right? Enabling the infant to take fluids and nutrition by mouth. And should the heart defect, whatever its form, be also corrected, recognizing that might prolong survival. But in this situation, the parents have requested the surgical correction of the esophageal atresia not be performed, fluids and hydration not be provided. So then the moral question becomes, should their wishes be respected? So if we turn to the principles as one way of questioning this particular case's heuristics, one begins to ask, first of all, what does respect for autonomy mean in this particular situation? Thoughts? I don't have to be the only one talking. I hear my voice all the time.
Is anyone else talking? No. Okay. So how we see these kinds of cases is also depending on the time when it happens, right? I mean, if this had happened, like, I don't know, in the early 19th century, we wouldn't even consider it, right? But now we have better technology, now we have better interventions, and I just wonder if giving the chance of this kid to live is actually uh, worthy. Will the kid arrive to a point in which they are capable of making contributions to society, or do something meaningful for their life? And if they are not going to arrive to that point, then is it worthy to extend their life if we know they may be suffering? So I really don't know. I guess that if we had better interventions that could give them a life that is worthy, and also that's a matter of discussion, right? Like, what is worthy for me is different from what is worthy for everyone else in this class. Um, so if we had better interventions, maybe it would be not good to follow what the parents want. But if we don't, then I don't know. I think we should respect the parents' choice.
Okay. Thank you for sharing those thoughts. So I think you're circling on a few different topics. So one of the important topics you're talking about is, in many ways in healthcare, technologies ultimately create the ethical situations that we have to confront and deal with, right? Because of the availability of a technology or a medical intervention, we are afforded the opportunity to make decisions. Neonatology wouldn't even be a specialty if it weren't for the creation of the incubators that happened back in the 1960s, which actually allowed us to take care of little babies born early. Neonatology wouldn't be a specialty if we didn't have little plastic tubes that were soft enough they could be fed into babies' mouths or noses, which didn't happen also until the 1950s to 1960s, right? So the technologies that become available to us, and I'm not talking about technology with the capital T in the Heideggerian sense of a single technology that's moving us forward, but rather different technologies create different opportunities for decision making and different possible moral choices. The second thing I heard you talk about was beneficence, right? So asking that question of what's in this child's best interest, how can we understand what an interest is? Is interests tied to just saving a life and keeping a baby alive? Or is interest tied to something more than just being alive? Does being alive mean more than being able to breathe? But does it also involve some kind of contribution to society or other fulfillment of purpose? And then the last thing I heard was, ultimately, parents should probably make this decision. because parents tend to make decisions for their children, and they're given a lot of latitude from society to make what they perceive to be the best decisions for their children. Any other thoughts specifically kind of about autonomy in this situation?
I think autonomy here, it also depends if you're looking at the child's life or the parent, because if you look at just the negative obligation, you're not subjecting the patients to constraints. So by not letting the parent have a choice, you're giving them a constraint, but also by not giving the child all of the technology that is possible to help them, that's also a constraint. So it depends who you're putting the autonomy on.
Good. So usually in healthcare, we talk about the fiduciary responsibility, whereas healthcare practitioners, we're responsible for our patients first and foremost. And the patient here is the child, right? So we have a responsibility towards him or her. But on the other hand, do we not also have responsibilities to the family as well? Can we simply say they're not our patient, therefore are not our responsibility? So here's a few thoughts. Sorry.
I would like just to add something.
Yeah.
Okay, so the patient in this case is a newborn.
Yeah.
And I would just see like, okay, they need to talk to the parents to make a decision. But at the same point, it looks like a bias because the newborn actually cannot make a decision. What if that is actually an adult? How would that change? So is that meaning the parents should have that fatal decision? They have authority to make it, even if that they know that their child will be passing soon. Would that be the way that healthcare should respond? This is what came to my mind. Like the situation of the patient actually is kind of confusing because it's a newborn. And at what extent should we give the parents the ability to make a decision for their child?
That's a really good point. So I'll go to this next slide just to expand on some of the points you mentioned. So some people would actually say that a baby, a newborn, because they truly do not have liberty, right? They're dependent upon others for every activity of their daily life as far as nourishment, right? And warmth and security. Newborns actually lacking in liberty and also lacking in agency if you believe that babies do not make any or not have the capacity for self-reflection on their actions. They are without autonomy. So you can't talk about respecting the autonomy of a newborn. But on the other hand, we can acknowledge that babies grow up to be adults, right? Or young children and then adults. And they develop the capacity for autonomy. And one can also give the argument of who says your conception of autonomy is the right one, right? Why does autonomy have to be defined by liberty and agency? Does this mean that people who have various mental or cognitive impairments are forever not given autonomy? So one thing we can do is also look at the principle respect for persons, which is connected to respect for autonomy, which would be infants should not be treated as a means or objects for secondary gain, right? Meaning, ideally, whatever decision we're making for this child is for this child, not secondarily for me as a doctor, because you know what? I like having a full in ICU. I like putting breathing tubes in and chest tubes in and doing surgeries and stuff, right? It shouldn't be for secondary gain. It should be what's best for this particular child. But then we also can talk about respecting the autonomy of the parents or other decision makers, recognizing that this child is born to this particular parents and will grow up likely within this particular community, right? And the parents are uniquely situated compared to doctors, nurses, or others to have a perspective on what might be valuable and meaningful for this child's life, right? So provided surrogate decision makers are making reasonable decisions, forefronting their child's interests, their autonomy generally ought to be respected, recognize the unique relationships parents have for their children. The next thing we talked about was non-maleficence. Now, medical interventions in and of themselves always involve harms. I've yet to use a medical intervention that doesn't involve a harm, and that's why we tend to use the phrase medical intervention instead of medical therapy.
Sorry to interrupt, but we have a classmate who doesn't have a microphone, and she just
oh, sorry, I didn't see that chat box.
Something on the chat. Yeah.
Sure. So would this be referred to as relational autonomy in the sense that newborns' autonomy is mediated through their parents? Also, how do we make sense of the experience of the parents, which is undoubtedly a traumatic one? So I agree with you. One of the problems about principalism is it situates an uncovering or heuristic of understanding the ethics of a situation according to these different principles. And ultimately, when we're talking about, the parents, one would also want to ask questions of, well, what is it like to raise a child like this? What might the child's experiences in the world might be like? And that's where a phenomenological ethics might be very helpful, which I didn't want to go into today. We can go into next time if people like. Now, the notion of relational autonomy, I've heard that phrase thrown around in multiple articles by different authors, and it has very different meanings depending on who uses it. So the concept to me isn't very precise. So Taryn, I'm just going to need you to specify maybe what exactly you mean by relational autonomy, because we're all in relation to each other, but clearly parents are in a different and a very specific, unique relation compared to their child. Yet at the same time, autonomy points to respecting someone outside of their relationships with each other. So when you converge relational and autonomy together, it can also be read as a contradiction in terms. So I'll come back to that if you type anything into the chat box. And I'm sorry, I see there was also another one of what was the slide before, and I think I missed now what was the slide before, but I'll send out the slides to you, Keelan, if I'm saying your name right, if that's okay. So talking about non-maleficence, medical interventions in and of themselves involve harms, right? So you think about surgery, there's tissue injury with it, pain with it, and all the possible complications that come from interventions. So for surgery, wound infection, dehiscence of the wound, as well as the need for a cascade of medical interventions. So if we do surgery, we need anesthesia. If we need anesthesia, we need a breathing tube. If we need a breathing tube, we need a ventilator, right? Technologies gather. Maybe we should have done an ethics and technology. That would be fun too. So prolonging the dying of an infant can be considered as harm if such a life is one of never-ending cycle of medical interventions, particularly if we think about the medical interventions as a cycle of medical harms associated with medical interventions, right? And we have to be precise with our language here because many people live their lives with technologies that don't necessarily, yes, they involve certain harms, but they're also enriching to their life, right? Important point to make is artificial hydration and tube feeding can be understood potentially as a medical intervention and as harmful. When we use the language of tube feeding, we can also use the language of force feeding. By giving someone feeds through a tube, you're taking away their ability to take the food on their own volition or decline that food. So it is a medical intervention, even if you're giving breast milk through a feeding tube. Just as giving IV nutrition is also a medical intervention. And in our society, medical interventions, it's reasonable to discontinue them, right? How about beneficence? Medical interventions that offer a reasonable chance of success should generally be provided. But as that was pointed out in the first comment, what do we mean as success? And this is a really nice example of specification. So vitalism is one, you can describe conceptually as one way at looking at life. So vitalism holds that life is in and of itself of ultimate value, no matter what form it takes, such that medical intervention should be pursued to preserve life regardless of the unfavorable consequences of the interventions. And I think many of us can recognize certain religions, cultures, and perspectives are implicitly or explicitly vitalistic, right? Now, vitalism contrasts with sanctity of life, right? Sanctity of life still recognizes the intrinsic worth of life, right? No matter what forms it takes. But we tend to make distinctions of actions that preserve compared to actions that end life, right? So generally, people who hold either a vitalistic or a sanctity of life view of beneficence, both would argue against active euthanasia or medical assistance in dying, because there's something intrinsically worthwhile, a value of life such that it shouldn't be violated. But on the other hand, generally people of a sanctity of life doctrine would be more likely to agree towards limiting the use of medical interventions with the possibility of prolonging life, meaning discontinuing mechanical ventilation, not pursuing surgery. Does that make sense? And still, one other perspective that we see in the literature or expressed by people is an instrumental view of life. So life is valuable insofar as it allows for good. Now, what is good? We all have different perspectives of that. Good could be, as was previously articulated, contributing to society. Good could be engaging in meaningful relationships or having meaningful or valuable experiences, being able to interact with those around you, whether that's in the form of speech or not. So from an instrumental view, life is foreseeably violable, such that it would be morally appropriate or reasonable to discontinue medical interventions if a child is no longer supported for a life with quality from them, okay? And so there's two philosophers, Verkeek and Lindemann, I guess they're not philosophers, clinician ethicists, would look at three considerations. So where it would be reasonable to discontinue a medical intervention. If the medical intervention does not improve the situation, so we can't change the fact a child has trisomy 18 by performing surgery, right? By giving IV fluids and hydration. Essentially, surgery and hydration is medically futile as far as correcting a genetic diagnosis. But on the other hand, it's not physiologically futile. You can reconnect the esophagus and give feeds. Right? It might be effective, but it would cost the child and perhaps others too much to get the improvement. So this is a question of disproportionality, right? So putting someone through such a horrendous pain, suffering, or other interventions, is it really worth it? And I can tell you, a child who has trisomy 18 and esophageal atresia and a congenital heart disease defect, you know, by the time all those surgeries are done and recoveries in the eyes, this child would likely be in an intensive care unit probably for 4 months and in hospital for at a minimum 6 to 12 months if they survived. So is that proportional to a survival of only a few years?
For me,
Did you want to just leave everything the way it is here?
Yeah, okay, sure.
There was one tiny thing. The printer is not working on this. I don't know if it's actually plugged in.
I see.
If it's not plugged, or if it is plugged in and it's not working, then it's supposed to be the bulk.
Right.
But I couldn't actually see where the wire
We
is
tell him.
going without.
Tim, you're unmuted right now.
Okay, yeah. Oh, that's good to know. Okay, well, thank you very much for doing this. I'm very appreciative.
Thank you.
Okay,
I would forget it the week.
thanks.
And then the last is the ultimate quality of life achieved would be very poor. And then there's justice, right? So medical intervention should be available to all, regardless of to whom one is born to and what beliefs their decision makers prescribe to, right? So how is it fair that because one child is born to one parents, they get a medical intervention, and another born to another set of parents doesn't get the same medical intervention, right? On the other hand, medical resources should be allocated in such a way that no individual receives a disproportionate amount of resources, right? So is it fair that we, give, hundreds of thousands of dollars to one child to try and keep them alive for 3 to 5 years, when we have children in Edmonton who don't have lunch in the morning or breakfast in the morning, or live in very socioeconomic disadvantaged situations? How is that just? So the reason I'm kind of dwelling on each of these principles is to show how they have an organizing effect in questioning the morality of a particular situation. So they're valuable as heuristics. But I'm hoping you can also appreciate that depending how they're specified, meaning depending on how we make them abstract to concrete in this particular situation, they can come into conflict with each other. And this is where this notion of reflective equilibrium comes about. How do we ultimately deal with specification, ranking, and balancing? And if we say that these principles are ultimately drawn from some kind of common morality, then ultimately how we balance them, this equilibrium that we come to, should also ultimately still also reflect the common morality of the society in which we live in. So in North America, where respect for autonomy tends to be regarded as the cardinal principle, which is not true in all cultures, right? But very much in Canada, we're influenced by the United States. And I think we all know from watching any news how important liberty and autonomy are in the United States. If parents are pursuing a goal of care decision that they perceive to be in their child's interest, and this choice is recognized to be within the scope of reasonableness, physicians are obligated to support it. Meaning a physician's autonomy doesn't trump a patient's or circuit decision maker's autonomy if the decision is being made from a reasonable choice of actions. So in this situation, I would expect that the parents very much would be supported in their decision making. Does that make sense? But here's where I'd like to have some discussion from you guys. So if we recognize that moral philosophizing ultimately draws on the morality of the day, right? Engages with what's socially, culturally acceptable. I mean, it's very possible, after the recent Supreme Court confirmation, that we may be seeing changes in laws around abortion and women's rights in the United States. What is considered as socioculturally moral may be redefined. What does that mean for ethics in the future, right? What do you see on the horizon as reshaping how we deal with ethical situations? Are the same principles of respect for autonomy, justice, beneficence, non-maleficence, beneficence, the ones that are going to guide medical practice in the future? Are there other principles that we foresee as being important? Are there different movements within ethics that we see are going to come to the forefront as others disappear? And of course, who are going to be the writers of policy guidelines and so forth in the future? Because we know often our histories tend to be smoothed out, right? Even just looking at the proposed educational reforms in Alberta that were leaked to the media, and trying to imagine how Canadian history may be rewritten for young children, right? Like de-emphasizing residential schools, right? And looking towards other to rewrite the history of Alberta. So how might the past shape the future, but also the current writers of the present shape the future? So I think I've talked too much, so maybe we'll just leave it here, and I'd just like to ask you guys your thoughts.
there's always an awkward silence after someone asks a question. So I'll start and then we can all say things. I think that if we take into account other classes that we have seen where we have been taught that there are these new computers that are collecting data and that can analyze information very fast, maybe we can use those computers to introduce all these very difficult cases to analyze and see how they were analyzed by humans to establish a precedent within those computers so that they can suggest courses of actions in very difficult ethical situations in medicine. And maybe that could be a strategy that we could use to write what is the code of conduct that we should use in the future as humans. Not the machine doing everything, but suggesting potential options to follow, right? And who will be the writers of policy? Oh well, yeah, I think it's the machines and us. And I think the past does shape our future, but we are evolving. And as an example, we talked about the technologies that could allow us to provide better care for everyone. So maybe we can take advantage of how in the past similar situations have changed because of the technologies that are coming into place to help others. I don't know if that makes sense. Anyway, yeah, so I broke the silence. Now everyone speak. Yeah.
Thank you, Eduardo. It's fabulous to have someone break the silence. I just want you to know that. So thank you.
I can, on a couple things that you touched on, I guess, I think in like a utopian world or like a very like positive spin on it, if computers were to decide these like moral questions and give us answers and help guide us, that still doesn't mean that the people who are writing policy right now, which is the government and different huge organizations and stuff, actually listen to it. Because you can see that now that we still, and I think from a scientific perspective, we're used to being like, well, yeah, this is what the answer is, and this is probably the best way to pursue it. But even now we present science, and that doesn't mean that society or the government is actually accepting it and following that. So I think that's, yeah.
So I guess as far as the first comment kind of around, machine learning and identifying patterns, right? So clearly right now we have many technologies that are far better at identifying patterns than people are, right? And one of the biggest issues always in ethics is this divide between what is and what ought to be, right? So how do you engage with machines or technologies to get at that gap between what is and what ought to be? Because it's not simply describing what happened, it's what we think ought to happen. And one thing that can become really challenging is how we basically quantify or take something quite often conceptually broad and make it into something that we can then subject to a pattern analysis, right? So a nice example of that is, in some of the epidemiology studies that were done around COVID, which initially said that, look, individuals who are Black in the United States have a higher likelihood of dying from COVID, right? But what's ethically problematic there is that we shouldn't be taking Black as a variable right? We should rather be looking at the social determinants of health within that particular racialized group to understand that it's not that you're Black that means you're at a higher likelihood of dying from COVID in the United States. It's that if you have delays in ability to seek care, right? Or you have baseline issues and poor health. So one thing that we always are struggling with in epidemiology research and also machine learning is not just, you know, what patterns do we find, but how is data entered into? But that doesn't mean that machine learning couldn't be very interesting, right? The other thing that was brought about was, you know, coming up with guidelines, right? So just as an example for COVID-19, right? So what variables are actually morally reasonable to use to guide decision-making? So if we find out that people who are more than 80 or more than 70, right, are more likely to die from COVID-19 compared to people who are younger, do we feel comfortable that age is used to affect decision-making? Even if it might be scientifically sound that if we're going to distribute resources, that people who are older are less likely to survive if given those resources compared to people who are younger. But are we still comfortable being ageist, right? And how guideline writers often get around this is rather than use terms like disability, they'll use terms like medical complexity, right? So a different way of describing a variable that is more socially acceptable than to ever prioritize care or exclude people who are disabled, right? Anyway, just some thoughts in response to both those really good comments. Other thoughts that people had from the group? Oh shoot, I created that awkward silence.
No, I have another, just, I would like to follow up what Ashley said, and it's true. Maybe we can present many of these scientifically sound suggestions to follow, and we can say, look, you know, we have done this study. It shows that it may be promising to follow this set of rules. But then, how do you deal with the societal background and cultural background that may be slowing down or stopping people from following that up? I think that's a big challenge, and I don't think we have an answer right now. It seems sometimes that we show data and maybe we are not showing it in an easy to understand form so that people grasp the relevance of the data. I feel that's the problem, because there's a lack of proper communication or a bridging between scientists and everyone that is not a scientist, that is specialized in their own field, but they don't understand what we're doing. And I wonder what would be a good way to decrease that bridge. And I don't know if anyone has thoughts. My thought is that it should begin since people are very, very young, in children. We should provide them with the proper tools to be objective and critical and to observe everything that is presented to them. But I wonder if that would pose a challenge for governments to control large groups of people. Because if everyone is objective and everyone is questioning everything, then probably the government won't like that. Like, oh, we cannot control all these people that think. So I don't know. That's my.
There are two sides of critical thinking need to teach critical thinking. One is to teach it to people, but the other is we're just assuming that as computers become more adept at predicting and handling this stuff, that computers won't also have defects, and there won't be a lot of sort of accidental elements in the computer prediction or computer suggestions. So actually, both are worth addressing, not just teaching critical thinking to people, but making sure that the results that we're getting from these sentient computers are as good and sound and helpful as they can be. And we're not giving them some sort of special honor just because they're, objective. It's a non-human source. And isn't this great? They can tell us what to do. Yeah, so I see equal challenges on both the human and the machine side.
Yeah, but so how would we get to a point in which everyone can, if the information is coming from a sentient computer or from us humans, how do we get to a point in which the set of rules is followed by everyone? Because that was the challenge that I got.
Yeah, well, you can think about the way politics is changing. What politicians used to be doing is describing a vision for the future that fits their own particular ideas, right? Now, almost no one is describing a vision of the future, because nobody really knows what's going to happen. And so the basic idea of what politicians are doing and what they're actually talking about is changing because of this feeling many people have that the future now is absolutely unpredictable.
I put a book into the chat box in case some people are interested, by Peter Paul Verbeek, who's a Dutch phenomenologist on moralizing technology, and clearly trying to get at how is it that things in and of themselves can be described as moral. And now, I mean, clearly, people have written about this, back to Andrew, to Albert Borgman and so forth. I'm not sure how much you dealt with Borgman in your class, or Don Idy, or other kind of media ecologists or philosophers of technology. But yeah, there's always this question, how is morality caught up with things? And then another, just a phrase I heard that someone mention is this notion of objectivity. Well, there is no such thing as objectivity. There is just an objective subjectivity, right? So if you understand subjectivity as one's grasp of the world, then a computer, as we currently see it, grasps the world in a particular way, which is different from how, say, a dog grasps the world, which is different from how a human grasps the world, right? So we have to be careful to ever give some kind of a particular veil to objectivity, because we're just dealing with different subjectivities. And that's a really important distinction to make when you're dealing with matters of morality and ethics, because you're ultimately dealing with questions of meaning, right? If that makes sense.
So we have 1 minute left in the class period.
Or just one quick question. Do you think that we should write these guidelines of how to live life thinking in a pessimistic way or an optimistic way? Like thinking as, oh, the world is going to end and the climate is just going to hell. or should we look forward in a way in which we see we are going to find solutions, but we need to begin writing these guidelines of what is a a worthy life to, or how to live a worthy life in a positive way.
I mean, I think we should write any such policies, guidelines in a manner that's hopefully as truthful as can be to our current situation. But we need to, the critical point is we need to recognize that any kind of, professional codes of ethics, whether you're a researcher or whether you're a clinician, that these are socio-cultural documents and they change over time. So we can't be dogmatic in simply following them, but they need to constantly be subjected to questioning and constantly ask, well, why is it that respect for autonomy is the prioritized or cardinal principle in North America, right? If you look at, like China's response to COVID-19, that's, I mean, I don't like to speak in a broad way about a whole culture, but clearly, in a more socialized culture, autonomy isn't necessarily as important as justice, right? That everyone's treated fairly. So a higher sense of social responsibility within a society may lead to a more concerted response against a threat to society, like a health threat. So maybe we need to look beyond our individualist autonomous preoccupations towards something that's more social.
Thank you.
So I get to see you all in 1 week's time, right, Kim?
Yes,
Yeah.
that's right. And we look forward to part 2 very much. Thank you very much for today.
If anyone does want to email me any specific questions or topics or anything, I can try and incorporate it into next week. Just try and give me a few days. But I'm looking forward to seeing you guys again next week, and I hope today was useful.
Yes, it certainly was. Okay, thanks.
Take care.
Thank you.
Bye.
Bye.
Bye-bye.